Let's turn to our clinical lecture for today. Our speaker is our good friend, Dr. Timothy Kosinski. He's a highly sought after speaker and a tremendous teacher in the world of implant dentistry. He's taught hundreds and hundreds of courses, written dozens of articles, but even more importantly, he's been a mentor to many dentists as they successfully add implant dentistry to their practices. He's also the editor of General Dentistry, which is the official journal of the AGD. And he's got another great lecture for you today. So I'm going to turn this over to Dr. Tim Kosinski to present Successful Implant Overdentures. And you're going to enjoy his teaching style and his way of making this information really straightforward and relevant to your practice. So Tim, it's all yours.
Well, welcome everybody, and thank you, Neil, for the nice introduction, and what a great business section. I always learn so much. I was taking notes as we were going through. So today's topic for the next 40 minutes or 35 minutes or so is something that's near and dear to my heart. Being from Detroit, we all know that Detroit was the hardest hit economy in 2008, and certainly things are changing with the automotive industry. I'd like to talk about overdentures and having successes with overdentures. I know that is not necessarily the hot topic in implant dentistry education today. We're all talking about fixed restorations, and I know in our courses the doctors are scurrying in to learn how to do these very complicated full arch implant prostheses, which are wonderful. It's a wonderful procedure. But fairly complicated and also sometimes financially restrictive to our patients. I'm an educator even with my patients, and I always tell them my job is not to sell them anything, rather my job is to educate and instruct them and make them aware of what is available. And certainly overdentures is a godsend for many of our patients that are wearing conventional prostheses, conventional dentures, and are struggling either from gagging in the upper complete denture, or a lower denture that just isn't retentive, that moves around, that creates sore spots. We know that as time goes by, bone is lost underneath dentures. There's no tooth support, and that creates a whole different scenario of problems for many of our patients, especially our elderly patients, who again may be on fixed income. So for those who are listening today, I don't want you to rule out overdentures as a viable alternative to our conventional dentures and our more involved all-on cases or fixed implant prostheses. So what are our learning objectives today? Very, very briefly, we're going to talk about indications and benefits of overdentures, which I think are a very, very important thing that you discuss with your patients. It's not our job to make the final decision. I know the lab, the Glidewell lab, has wonderful models that I think you should have in your offices. They demonstrate overdentures and our implant retained fixed prostheses. We're going to understand the options for case design and the attachment system that I use most often today. Obviously, I've been practicing for a long time and I've gone through many, many systems over the years, but we're going to specifically discuss probably the most convenient, cost-effective retentive device, and that is the locator attachment. We're going to learn predictable techniques for chairside attachment pickup. This is important because I know many of you have done overdentures and the patients struggle with it. The attachments or the clips wear out very quickly. The prostheses rock. And as general dentists, what do? We bring the patient in and we increase the retention of the locator attachment in the denture, but it still wears out too quickly. These attachments should last a year and a half easily before changing over. And the problem that most of us have is that we take a direct impression of the implant body itself, and we rely on our laboratory technicians to process our final locator attachments in our prostheses. That's a problem, whether we digitally scan it or we do it with analog impression material, is that we have both the locator attachments, the locator overdentures are both implant and tissue supported, and tissue moves. And so we can get some inaccuracies in an overdenture by taking a direct impression of our implants to make our final overdentures. So I'm just going to very briefly discuss two different ways of addressing this problem. One is a direct impression of the locator itself, and the other is chairside processing of the locators, which I find to be the most beneficial and a most predictable method of giving awesome stability. So again, for those of you who have done overdentures and struggled with it, get frustrated with it, hopefully we're going to be able to resolve that issue once and for all in the next half hour. And we're going to talk about how to adjust and maintain overdenture cases. I think maintenance is very, very important, especially in our elderly patients or patients that have manual dexterity issues. Oftentimes we have to have family members or caretakers understand that these attachments need to be cleaned properly. We all know, I'm going to go through this very quickly. We know when teeth are lost, bone shrinks, right? It shrinks down and in the lower jaw, up and in the upper jaw, and it creates some problems for us over time. Why do many general dentists not place implants? Well, we're concerned about two things. We're concerned about the mandibular nerve, because we know that the bone shrinks in the posterior mandible. We're concerned about where the canal is. We don't have enough room to predictably place our implants. And so we're stuck working in the symphysis area where there's adequate bone anterior to the mantle foramens. In the upper jaw, bone is soft. It's not as high quality dense bone as in the lower jaw. And when we lose a tooth, oftentimes the sinus itself will fall or collapse, creating a problem where we just don't have enough bone without doing a more invasive bone grafting procedure or sinus augmentation procedure to properly place the implants. And of course, placing the implants is very, very proper placement of these locators is critical to the success. I'm going to put a cough drop in. So according to Dr. Mish, it's really an engineering principle that we have to address, and placing our implants in the correct position will increase our retention and our stability long term. We know, and all of us know, that we can cantilever any prosthesis 1.5 times the AP spread. What does that mean? If we draw a line from our most anterior implants and a line through our most posterior implants, we can actually cantilever without a lot of rocking 1.5 times that. So spacing of the implants is very, very important to increase our stability and allows us to eliminate the palate in these procedures. Now, this is really a big education point for our patients, especially patients that have worn dentures for many years. We're eliminating the palate. We have taste buds on the palate. Food will taste better, gagging reflex will be totally eliminated, and they have an dramatically improved quality of life and increased function. The literature will say increased function up to 60%. Very important things to discuss with your patients. However, depending on the bone volume, bone shrinkage, we have to decide how many implants can we place, where can we place them, and how can we best stabilize the denture. It is still a denture, doctors, and make sure patients are aware of it. They still have to take them out. They have to clean them. They have to let the tissue breathe periodically. But again, maintenance is very easy. One point with overdentures, and I just discussed this with a patient the other day who was contemplating fixed prosthesis versus removable. What's the function? What's the benefit or risk of either or? Now, if I place 4 implants for an overdenture and I happen to lose one, I can easily replace that implant and convert the existing overdenture that I made with that lost implant or the new one that we placed. If we have a fixed implant prosthesis and we lose one, oftentimes we may lose the entire case, which means we have to start over. And who is financially responsible for that? So those are very important considerations that are very important to me. So you really have to address the patient's concerns, needs, and goals. Don't oversell your abilities. Rather, work within the patient's budget and expectations. I can convert an overdenture to a fixed prosthesis down the road easily. We want our locator attachments to be nearly parallel along the axial plane. This allows for passive fit of the overdenture. We can do these free-handed. We can do it guided. Guided surgery is an outstanding tool to help us virtually place our implants in ideal position prior to any surgical intervention. We don't necessarily have to have a guide that places the implant directly through the guide. We can do simply a directional guide to help us angle the implants in the correct position. And angulation, again, is very, very critical. Again, many of you have had problems with overdentures, and it's because the angulation is too excessive, which means that the attachments are wearing too quickly for our patients long-term. So what do we do? How many implants do we place? Can we place 2? Well, if you have a person that doesn't have a lot of masticatory muscle force, 2 implants is better than no implants. It'll create retention, but it is still a denture. You have to explain it to the patient. They still have to take it out, clean it. Sometimes food will move. And as I mentioned before, these are implant and tissue supported. Placing 3 implants will increase the stability, increase the anterior posterior spread, the AP spread, which will give us a little bit more stability. Very critical, doctors, and this is for another lecture, maybe, Neil. Attached gingiva is critical around the facial aspect of any implant. So doctors, you have to be in tune to attached gingiva on the facial aspect of your implants for long-term predictability. I've been doing this for 36 years, and believe me, I've made enough mistakes over the years to realize that. Placing 4 implants in the maxilla is my minimum, and I'd like to have an anterior posterior spread, an AP spread, if I can. But again, it all depends on the patient, the bone volume, the bone quality we have in a certain situation. The slide on the right is a direct impression cap. So I am choosing the locator attachment that I'm going to engage or torque into my Hahn dental implants. The correct height of those locators is measuring the thickness of the soft tissue. And you can do that with a perio probe. That's what you order. That's what you instruct the Glidewell lab team to provide you. So if the tissue depth is 3 millimeters, you order a 3 millimeter tall locator. That means that the locator attachment is 1.5 millimeters above the soft tissue. I find this to be most productive. When they're too tall, oftentimes we have a little bit more issues in seating those prostheses predictably. So invest in these direct locator impression copings. So I'm just simply snapping them in. I'll make a custom tray and I'll take a final impression of these attachments. We have analogs that mimic the locators that are in the mouth. So here again, ideal position, attached gingiva. We're placing these direct impression copings. We have laboratory analogs, or the laboratory will have laboratory analogs. And this is probably the best method to take a final impression for a locator attached overdenture. Much better, much more predictable than taking a direct impression of the implant itself in the bone. So very briefly, the locator system is used for overdentures. I use it for partial dentures in the maxilla and in the mandible. They're self-locking. We torque them into position at 35 Newton centimeters as you would an abutment screw. It allows for, because of the height of the attachment itself, we don't need a lot of interocclusal space. We all know that with our implant retained prostheses, our screw retained or all-on prostheses, we need 14 to 16 millimeters of interocclusal space per arch. So oftentimes we're removing bone to provide this service to our patients. With the overdentures, we need 8 to 12 millimeters. So we don't necessarily have to remove bone. And you've heard me say this, if you've read my articles, bone is gold to me. Maintaining the patient's available bone is the best way to treat them long-term. I'm talking 5 years, 10, 20, 30 years from now, as bone is naturally going to shrink away. Retention is within the attachment itself and then the outside surface of the attachment. And this gives us tremendous stability. What I like about the system is we also have a variety of retentions, and changing these attachments, these nylon attachments, is a simple process. It's really a quick appointment. I'll tell the patients, usually we change them in a year, as short as 8 months to maybe a year and a half. When they start feeling a little loose or food's trapping a little bit more underneath, come on in and we'll change it. We do charge. In my practice, after we seat a case, the first changeover to the next heavier retention is no fee to the patient. It's built into the prosthesis itself. It allows for pivoting, so we can have some discrepancy in angulation, but we have to make sure that the prosthesis seats completely. Sometimes we'll have patients, we will try it in, we're happy with the case, the patient leaves, they come back and they go, it just pops out with my tongue, I can just lift it up. And the reason is they have to forcefully seat that prosthesis completely. And oftentimes, if they don't have a lot of manual dexterity or strength, they're missing that. So make sure that they understand that you don't always hear the snap, but you feel the retentive device going into the in the mouth. It has to seat completely. So if they're lifting it with their tongue, it's because they're not seating it correctly. We can have some discrepancy, 20 degrees between implants. We have extended range attachments for those implants that are a little bit more divergent, up to 40 degrees between implants. And there are tools, there are tools that Zest will provide that allows us for angulation. So there's a lot of thought process into our implant prostheses. It's more than just placing this fixture or this spark plug into bone. Think tooth or teeth first, teeth up. We want to idealize the position, the size, the shape of the implant, and what our final result's going to be to maximize or give the patient the best result possible. So let's go into some clinical things. Implant retain overdenture. Here's a patient that has very little bone, elderly patient. We did a CTC analysis. You can see I don't have a lot of bone. I have no bone in the posterior mandible. This patient's quality of life is diminished extensively. She just needs a little stability. So I was able to place carefully 2 Hahn dental implants in the symphysis area, away from the mental foramen, away from the nerve. If you're not sure of the positioning and you do have CBCT in your office, do a pilot burr, take another CT, make sure you're angling those implants ideally in the available hard tissue. Here we have healing abutments. We remove those healing abutments and you can see we do have a band of attached gingiva on the facial aspect of these implants. We must have at least 2 millimeters to be effective, but having 2 implants real close together in the symphysis is going to create some retention, but the denture is still going to move. So what I had the team at the expert implant team at Glidewell do is they milled a bar connecting those 2 implants. You can see the abutment screws going into the implants, and I was able to extend distally somewhat and place 3 locator attachments in an overdenture. Now, doctors, this is a little bit more expensive, the lab work, so I want you to talk to your technician before you present fees if this is the type of situation you want it to provide your patients. It's a little more expensive than freestanding. but it is going to give us more stability long-term for our patients. The overdenture is fabricated. These are the laboratory locator attachments. They have very little retention, but they are very easy to remove, and then we will replace them with heavier retentive devices. So here you see this bar that the patient can clean easily, either with a water pick, floss threaders, and we were able to increase retention and stability by making this milled custom bar with 3 locator attachments. We remove the laboratory, and I just use a scaler, and I'll just pop them out. And then we can replace with the proper locator attachment. Now, if they're elderly, if they have some dexterity issues, I will place the lowest retentive device initially. I don't want them to be frustrated in taking them out, because if they're frustrated, they won't take them out and they'll have a lot of debris and everything underneath. See these patients afterwards. See them a week or 2 or 3 weeks later, or if they have any sore spots or whatever, make sure that they know that they are welcome to your practice to make any adjustments. Make sure that those prostheses seat completely. Take the time, or have your staff take the time that they can put them in, take them out, and how to maintain them. If you need a caretaker to be there in the room, that's very important. If they didn't bring a caretaker and you need it, schedule another appointment, either with the hygienist or with your team member. And you can see there's a big range of attachments or retentive devices, which I love. 5 pounds, 3 pounds, 1.5. And the extended range, again, is if the implants are a little divergent. We don't have that internal retention device, but it is an excellent tool. You need to inventory these in your office. Make the investment so that when the patients come in, if something's loose or something negative happens, that you are able to resolve that issue immediately in chairside. Choose the locator nylon mail determined on the angle measurements. You can have up to 20 degrees divergence with between 2 implants. With the longer term one, we can have the extended range ones. We can have divergence that is extended up to 20 degrees between implants. So here's our final implant retained overdenture that is snapped into position with a milled bar. Challenging situation, but certainly within your wheelhouse. Post-operative CBCT analysis, and we're able to provide function opposing a conventional denture, making the patient's quality of life dramatically improved. Rather than having a mouse pad just sliding over a table, she now has function beyond what she could have expected. Good oral hygiene is critical. Water pick, floss threaders, make sure that debris does not stick inside the locator attachments. We see that oftentimes. Again, patients that are maybe in nursing facilities, we have to educate and instruct those patients and caretakers how to maintain it. Soft nylon bristle or end-tuft brush is a good way to keep the areas clean, but you must have a band of attached gingiva on the facial aspect of those implants. Non-abrasive gel toothpaste is recommended to keep the socket of locator attachment clean. Another situation where we have a patient that is wearing conventional dentures, quality of life is diminished. This is what we see all the time in our practice. Patients are really challenged. Their quality of life is diminished, and they're coming to us asking us specifically about implants. And you can see the CBCT analysis in the upper jaw. We have adequate bone to place implants as far back as the second bicuspid area. In the mandible, we really just have the symphysis area without doing more invasive procedures. Here I'm making a reflection. I want to see the available hard tissue clearly, and then go through the process, the Han surgical process of placing the implants ideally. I did these freehand. You can do it guided. You can do directional guides. That's a whole nother program, Neil, again, that maybe we can discuss when to do directional guides versus full guided surgery. But our implants are nearly parallel in a panoramic view, in good position. We evaluate post-operative CBCT analysis, indicates that we're in viable bone. Now, this is what we conventionally do, right? We do a bone or an implant level impression. We put impression posts. These are open tray. The team at Glidewell is exceptional, second to none. The implant team is second to none. And they have a lot of literature of all the steps. One of the other issues that I hear often from doctors is timing. When patients get started, how fast can they get it done? They will give you specifically the time frame and exactly what you need to do for each step to maximize the final prosthetic result. Because you know what, doctors? That's all that matters. You know, if you have to take a couple extra steps because the wax trying didn't look good or whatever, yes, it's inconvenient for everybody involved, but what the patient remembers, what you remember, what your team remembers is the end result. A happy patient is going to refer other happy patients to you, and that's how you're going to become even more successful. Listening to the team. So a implant level impression in the laboratory sends me back a stable occlusal rims and set a couple teeth for the anterior, and we do our bite relations, tooth position a la conventional dentures. We send that back to the lab. They did a wax setup. We go through the process of approving it. Our midline is off a little bit. Comfort, tooth position, size, color, all the things that we do with conventional denture techniques. But we have stability here. We have our laboratory attachments so that we have some stability in our try-ins. Now here I'm measuring the soft tissue. I'm measuring the soft tissue and we have, what is that? Maybe 4 millimeters. So I would order a 4 millimeter locator attachment. That indicates that we have 1.5 millimeters or so supra crestal, supra tissue area. If you go too tall, sometimes there's an issue here. I choose the locator attachments. The laboratory can do it also. It's all up to you. Be aware of attached gingiva on the facial aspect of our implants. We torque these to position to 35 Newton centimeters. And I want to show you, we're going to end up, Neil, with a little video of how I do this chairside, how I process these attachments chairside. So we use the quick up system. There's different systems. We have the process denture that we approved. We have the locators. This is on a model, okay? We have the locators. We have the locators in the mouth. And as I said in the very beginning, sometimes we have a little bit of discrepancy between implant and soft tissue. So I'm doing a bite relation. Remember, we approved all the setup, the aesthetics and everything ahead of time so that we don't lose that positioning. Just a bite relation. We'll separate that. And here's our attachments. Now we have a little ring. That white ring will go onto the locator itself. That's kind of a block out ring so that our acrylic doesn't lock in. That's happened to me once. You only want it to happen to you once. So put the little ring on each of those locators. And again, I find this to be the most accurate way of creating stability. So if any of you have had issues, be aware of that, and you can correct it by just doing this chairside. We have the housing with the laboratory black attachments that have very little retention. And I'm snapping them on, make sure they're snapped on firmly. And then with the pickup system, there's a fit tester. I like to place this material, it's a flowable material, underneath, just to make sure that I don't lock anything on those attachments. There's nothing more frustrating than locking material. So here I have the denture. It's processed, but the acrylic has been relieved. We'll put some adhesive in each of those receptacles, and they are relieved excessively, so everything is passive. There's nothing snapping. And this is our quick up material. It's gingerly colored. And filling the receptacles. Placing some on the counter to watch. Remember, it's going to cure a little bit faster in the mouth than it will on the tabletop. And I'm simply having the patient close into that predetermined position. As it cures, you can see the housings and the black laboratory locator attachments are easily presented. I clean it up a little bit, check it again. And then there's a flowable quick up material to fill in any voids that you may have, any little discrepancies that it's light cured in a laboratory, don't look at that. And I'll simply take a scaler, remove those black laboratory attachments. Clean and polish. So if any of you have had any problems with your locator overdentures or from another office, come back, remove the housings that are there and do this chair side. It will eliminate a lot of the problems. Here's the locator tool to actually seat the attachments into the overdenture. Again, pick the level of retention. I normally start with the lowest, depending on the situation, the dexterity of the patient themselves. And these simply snap, and they will snap. You will feel them snap. You turn the other edge and they are retained. You do this with all four. You can polish, and we're simply placing it. And remember what I said earlier, it's got to snap completely. And you can see I'm using quite a bit of force. I can't move it. It's stable. It's not rocking. These attachments will last a long time for the patients, improving their quality of life dramatically, increasing form and function, and again, giving that patient a quality of life. She or she's putting it in. Take the time, or have your staff take the time. Can it be frustrated? Oh, okay. She's happy. So far, so good. Oh, there's a smile. Now let's take it out. Let's see if you can take it out. Oh, wait. Huh. She's working it and she's thrilled. So again, Neil, you wanted me to stop at about 10:02, and we are stopping at 10:02, and I'm open to any questions or comments. Hopefully that was helpful. And I know that we're going to write up some of these cases in a special edition of Chairside later this year. So hopefully we're really going to improve your clinical skills, doctors, in your practice, and improve the quality of life of your patients dramatically with very cost-effective overdentures.
Fantastic, Tim. I have so many questions. We're going to stay a little late and try to answer all these questions because they're good ones.
Is that overtime, or am I on salary? I can't remember.
You're
You're California dollars, right?
We pay you twice minimum wage, right?
Okay.
So first question, when you were doing the treatment planning, you were talking about AP spread, and you said it could be 1.5 times the AP spread for the distal extension. But what about the anterior extension? Because I noticed on that case that you were showing, you actually could have taken the anterior implants more anteriorly. I mean, it can rock anteriorly, not just posteriorly.
So yeah, that's a really good question. Ideally, Neil, I would like to place the implants in second bicuspid cuspid on either side. If you go too far anterior, oftentimes the issue that we have is the thickness of the prosthesis and the lip support. We get a little fatness there. Every situation is different depending on the amount of bone that we have, and sometimes in the anterior it's really, really thin. I try not to remove bone if I can help it, Neil. I really try not to eliminate. I know so many doctors are removing 6, 8, 10 millimeters of viable bone, and that really concerns me long term, because I know what's going to happen to these people in 20 years. Their bone's going to be gone forever.
Absolutely. Absolutely. Okay. There's two issues here that I got several questions about, and I think they go together. So the first question is, do you do some of these maxillary cases with an open palate?
Maxillary cases with implants is always open palate.
It's always open palate. Okay.
And I don't want to say, I shouldn't say always. Sometimes if the
because you always do at least 4
ridge,
implants. Right?
Yeah, if they have very, very minimal ridge, and it's not the problem isn't the palate with these patients, rather that it's that the dentures don't have the a post dam, we don't have any stability there, then I'll do a full palate. But the whole idea of this is to eliminate the palate, and that's why they need to get models that you guys make, that Glidewell makes. You can show them, show the patients, you have this denture, look what we're doing. We have a horseshoe now, and there's taste buds on the roof of the mouth, and it's a miracle. It really is a godsend.
I just want to make it clear that you try to always have an open palate, but you also try to put in at least 4 implants
on the upper. Absolutely.
Yeah. Okay. All right. What about do you ever need metal mesh reinforcement on that maxillary overdenture?
That's a great question, and the answer to that is yes. Sometimes I'll even do a partial framework. It really depends on the muscular structure of the patient themselves. Sometimes it is a partial framework. The problem with that is converting it down the road if you have to change things when you have a mesh or whatever. So I try to work with the technicians, and obviously we've been working together for 12, 14 years now. They know what I want is where the implants are. I don't want any mesh right where the implants are. So if I ever have to replace one, it's easy to remove acrylic. It's hard to remove metal. So yeah, it depends on the individual. But you have frail,
Okay. And what about the opposing dentition? Is that part of your calculus too?
Exactly. Yeah. Mm-hmm. Great question.
Great. Oh yeah, these are good questions. Okay. What about, I saw you used a bar instead of freestanding attachments in that one case. Now that increases the amount of vertical space that you need, doesn't it?
Correct. But that patient had they had lost so much bone. Okay. That was really a miracle case, to be honest with you. Sometimes we're just trying to help patients whose quality of life has been diminished excessively. They're just not able to function with their existing appliance for maybe 10 years. So it is a godsend for them.
Okay, so that goes right along with another question that we have, which is if someone had a large amount of maxillary bone loss, so that means there's a huge amount of space between the arches. Is that a situation where they might be better off with a fixed, like an all on X kind of a procedure?
I think that our job is to make our patients aware of what we can do. And we've talked about this before, Neil. I kind of lead the patients into making the decision for themselves. And a lot of times it's a budget issue. It's simply a budget issue. Our zirconia prostheses, they're pretty heavy too. So, that maxillary bone is not dense, it's porous, and can create complications unless those implants are ideally spaced.
Right. Okay, good. What about, I know you've got a bunch of intraoral scanners in your office. Do you take that impression with a scanner? I mean, I know that there's scanning abutments for the locator. Do you do it digitally?
You know what? We have not. You know how many patients we see in a day, and we've got really efficient. And I think that is the future, no question about it. But it is a little bit time consuming for us. But I think that's a really viable alternative. I think that is the future as technology continues to improve. Absolutely.
Great. Got a couple questions about the pickup adhesive material that you used. Can you give us the name of that product and where they can get it?
It was Quick Up. I'm not sure who made it.
Is that,
Yeah.
I think that's a Voco product. Does
A
that sound
vocal
right?
product, right? And I think the team at Glidewell can recommend materials too. They're all about the same. So you know how we
Okay.
are as dentists. We like our favorites.
Okay, here's a good one for you. Ready? Hey, I've seen clinicians immediately load the implant and the locator, putting the overdenture in on the day of implant surgery. Do you do that? And what do you think of people who do that?
I don't.
Okay.
I don't. I don't have. I would not have a problem. I do. If I can torque the implants to 25 centimeters, I don't have a problem putting a healing abutment, and a locator is really just a healing abutment. So I have no problem doing that, but I wouldn't put the attachment. I would put a soft liner in there. I just don't want any pressure on that at all. If the implant moves at all, our patients, they'll start eating rocks.
Yeah.
And if it moves and then we lose it, and then who's responsible for that? We are, because all the patients understand is the end result. So
And
I
I so agree with what you're saying, Tim, because first of all, if you put a healing abutment on and you do a nice soft reline, you've already given them more retention than they've ever had before,
exactly,
right?
Neil.
So, and then
Exactly.
you tell them, well, wait till you get the final attachment in. I think that's a great way to go. Question about the pickup procedure. Do you create a vent to allow excess acrylic to flow through?
That's great. I have before, but I just haven't found it to be necessary, and it just creates an aesthetic problem for me. But
Okay.
I have seen that technique done. I have done that before. I just don't. I just make sure that there's we relieve it completely. Don't be stingy in how much you relieve. We can just put a little extra material there.
Okay. The question about for an upper overdenture with 4 locators, they're saying how much of the palatal can be removed. You're saying you can make an open palate unless there's extreme demands on it.
Open palate, and it all depends on the patient, the flatness of the ridge, itself. Obviously, remember, these are implant and tissue supported. The more tissue support we have, the more stable the prosthesis will be. So it becomes a compromise in how much we can remove.
Okay. This is an interesting question. How do you decide if you need a bar or not?
It really, the AP spread, and the I guess the facial features of the patient themselves. That one lady, 2 implants that were really close together in the symphysis. I knew that it would retain, but it was going to rock anterior posterior. So I wanted to give her a little bit more stability.
Does the size of the implant or the quality of the bone, does that enter into it? Like if you're using 3.5 diameter implants and they're not quite as long.
Sure. I mean, that makes sense. I mean, splinting, obviously, implant retained prostheses. We're splinting. That's the whole engineering principle behind it. Splitting implants, I think, gives them a longevity.
Okay.
Great questions, Neil. Wow.
I know, and they
Impressed.
just keep coming. The blue blockout material, who makes that? Where do you get
Yeah,
that?
it's part of the kit. It's part of that pickup kit.
Part of the pickup kits.
Yeah.
So that would be the Voco.
They call it a
product.
blockout. For like sore spots, but I just, because it flows really nice, I just injected it around. I just don't want anything to lock. I've locked it once. I never want to do that again.
Yes. What about the ADA codes for the everything after the implant? Can you share those with us? I know you don't have them offhand, but maybe we could send them out.
Can we call Jess and we can send those out? Absolutely.
Let's do that, Nicole. Okay, great. So interesting question. So if the patient's already wearing a complete denture, okay, when you place the implants, are you doing your reline on this and then do your pickup on a new denture? When do you decide if you're making a new denture or you're not making a new denture?
Great question. If the denture, again, finances can come into play, age, dexterity, mental capacity. We're trying to provide a service to our patients. And if the dentures have functioned well and they're adequate and the tooth positions are fine and the wear is fine, if I can use their existing denture, I have no problem doing that. I don't promise that I can, because a lot of it depends on the positioning of the implants themselves. And sometimes we have to change the design of the final prosthesis. But yes, I have done that. And I think that's a really nice service. to the benefit of your patient population.
Okay. Here's a question that
Uh-oh.
how do you reline overdentures? Do you reline them, and how do you reline them? Because I know
Well,
that's
again, you're not really. So when we have an implant is like a tooth, and it's going to maintain, theoretically, is going to maintain the height of the bone. The concern you have is the distal saddles, and bone will continue to shrink theoretically over time. So you could just do a conventional reline, whatever doctors do, of just the saddle areas, because where the implants are, it's very unlikely that you have to reline that site. Or start over, take that denture, grind everything out, and take another impression with those locator impression caps.
right. Or tell a patient it's time to make a new denture.
Exactly.
Right. Let's see.
Excuse me.
Oh, I got a question about the Zest company has a new fixed attachment that they say can be used for fixed prostheses. Any comments on that product?
Yeah, I evaluated it. I think it's that was around. I think they improved
Well,
it.
they pulled that one back. I think they called that the
it's great.
FTX.
Yeah,
and that didn't work
right.
out, so they pulled that back.
Yeah.
Now they have a new one.
Yeah, and the only concern I have with it, I think it's great, is number one, we know how debris collects on acrylic. It doesn't collect on our zirconia, our Bruxer, but it does collect on our acrylic. And that tool is a special tool to remove it. Patients have to be on board with maintenance. And if they leave, is another doctor going to know what to do, or are they going to damage it, not knowing how to remove that prosthesis? Because it's a special tool to remove it. I'm fascinated by it. I did not invest in it at this point, but I'm intrigued.
Interesting. There's a question about maintenance. You mentioned a non-abrasive gel toothpaste, and there's some research that says that stannous fluoride can cause corrosion of titanium. Do you advise your patients to avoid fluoride?
Yeah, I guess I haven't really heard. I'm not even sure what the locator. I don't know how they're processed or whatever, but I guess I haven't seen that. I mean, if they don't have any teeth, they're not rinsing with fluoride. And
Right.
you know what? They can brush with whatever they want as long as they keep the area clean.
I mean, to quote my friend Dr. Hochberg, if they were going to brush their teeth, they wouldn't be wearing overdentures now. Anyway.
Good point. Good point.
Okay, let's see. How often do the inserts need changing?
So I tell the patients right up, they're intended to last a year. That's what I tell them. But it may be as short as 8 months, and it may be as much as a year and a half. I've had patients go years without changing it, but other people are really particular. So as I mentioned in the program, my first changeover is on me. Okay, it's built into the prosthesis. After that, there's a charge for the and they know it ahead of time. It's maintenance. It's changing spark plugs. It's rotating your tires.
Okay. I've got a question about, you were very specific about the locator. You've had tremendous success and experience with the locator. Are there any other attachments that you use?
Yeah, at this juncture, no. We started with Joe Salk. Do you remember that name? With ERA attachments, and I remember publishing it when I was a very young man in the ADA. I think it was ADA or General Dentistry years and years ago, and that was our go-to for many years. It's not as convenient as locators. I think that and my philosophy, doctor, if you're going to invest in something, get really good at what you do. We don't need 10 different products in our office. You need one, and get really proficient at it. That's my advice to our younger doctors or doctors starting out in implant dentistry, is get really proficient in what you do. And working with the implant team at Glidewell, I mean, they make my job easy. They make me look good. You've heard my lectures. If you see something white, I didn't make it. I just created the foundation so that the laboratory technicians could make.
I want to just emphasize what you're saying, because you know, in my 44 years in dentistry, what I've seen is the really successful people are people that stick with one product. They stick with one implant system, with one lab, with, you know, just because then you become proficient in your technique. You know what to expect from the product. You know what to expect from the people, and I think it just works so much better. Dr. Kosinski, it's always a privilege and a pleasure, and today was certainly no exception. Wonderful lecture. The questions are still coming in. I mean, there's questions about Effordent. Yeah, what do you think about Effordent?
Yeah, no, you don't want them to use Effordent because it does wear the nylon. There's a system, and I can't remember it. I'm sorry, Neil, because the staff takes care of that. There's a cleaning system that we provide for the patients that they can buy online. We can get that information. Jessica can get it to you, and you can put it online for everybody.
Okay, great.
Not
great.
Effordent, though. Do not use Effordent. It wears the nylon attachments quicker.
Okay, no Effordent. Very good. Very good. Okay, thanks again, Tim, and thanks everyone for joining us. Thanks to the panel. The panel did a brilliant job today.
Very nice.
And be sure to join us next week when we'll have, as always, our business advisory panel. And our guest speaker will be Dr. Brad Eli, who's an orofacial pain and sleep medicine specialist. And he's going to break down the indications for oral appliances and how to select the right appliance for your patient. It's going to be a great lecture. So thanks to all of you, and we will see you next week. Take care. Goodbye, Tim.